Good morning. I am Dr. Anand Nigam. On behalf of UP Arthroplasty Society, I welcome you all on the 14th UP Arthroplasty course. Indeed, it is a great pleasure to be with you people over here. And to me and to my society and to my core committee, it appears a dream came true. Morgan Freeman, in one of his Academy Awards, laid down some principles for any society or for any community, which we followed etymologically. The first one is, slowest is the fastest way to reach a place where you want to be. We started in 2005. We propagated gradually with your healthy inputs, with your support, with your positive criticism, and of course your participation. We came to this level, and rest is a history. Second, always be surrounded by your people whose eyes get lighten up while seeing you coming. In due course of time, our delegates and our faculty become part and parcel of it, and everybody wants to see each other. Now it has become an UP Arthroplasty family rather than a society, and all of you are a part of a family. And third, and the most important, the top of the one mountain is the bottom of next. So never stop climbing. We never stopped climbing on that, and every year we try to introduce a new thing. Last time it was VR, this time we introduced robotics, nice of our learned faculty who gave the consent to be the faculty of the robotics. Because every time we should know where the word is and where we are. Only then we can propagate forward. Before that, in robotics, there are many things, the detail of which will be told you Dr. A.S. Prasad, my course director and my senior friend just after that. But before that, I would like to invite my core committee members to on the stage. Dr. Jha sir as my patron, Dr. Rajesh Jain, Dr. Loken Singh, Dr. Vinay Gupta, Dr. Vishal Agarwal, Dr. Amit Verma, Mr. Ashish Kapoor, Rajiv. These are our core committee members which started from the very inception and lasting with us. Dr. Prasad sir, we can't forget you. You are the core member, that's why I'm asking you to in the last. How can I forget you, sir? Myself, Dr. Prasad, we speak here, everybody listens us, but without these people, this program would have not been possible at all. Because they work day and day night with giving all the positive criticisms. And they were so critical that without this program would have not taken the shape. I cannot resist myself to say one couplet. जो धुन साथ से निकली वो सबने सुनी जो तार पर बीती उसका किसको पता. These all fellows are our wires because that our instrument would have not worked at all. Thank you very much for everybody. Now I request Dr. Jha sir to give us our blessings and permit us to open the program. Thank you, sir.
Thank you, Anand. Well, friends, it gives me a great pleasure addressing you all this morning for the 14th Cawnpore Arthroplasty course and the UP Arthroplasty course. Well, I will be very brief in declaring this scientific session open, and I would first of all salute all the speakers, all the masters who have assembled here to train those who want to learn. And I'm pretty sure you as masters yourself will also have something to take back home. For the organizers, I would like to say, may God give you the desire of your heart and make all your plans succeed. And for all the trainees, I would like to say, be fertile and master it. With these words, I declare the scientific session open. Thank you, Nigam.
Thank you, sir. Now I request my senior and course Dr. A.S. Prasad to give the brief outline of the course. It was our basic intention not to make it as a conference or anything. It should be a monologue, not should be a monologue, but a dialogue. And every time we have realized that most of the time the delegates learn from the faculty and the faculty learns from the delegates. Sometimes everything comes new. And I request Dr. Prasad sir to give a brief outline of this course. Dr. Prasad sir.
Thank you, Dr. Nigam. And good morning, friends. First of all, a warm welcome to you all. I'll just add a couple of things. This journey started in 2005. And I still remember I was doing resurfacing since 2002 December. But in our colleagues also, when I said I'm doing resurfacing, they were big question mark, what is this and how it will work? So that gave me an idea to organize a one-day event where I would show a live surgery of resurfacing. And Dr. Bolt was a friend, I had worked with him, so I called him to do that. And we did a one-day resurfacing program. But I also wanted to show another approach of doing hips, so I called Sanjay Agarwala again, who was a good friend from Mumbai. Professor Jha was there. And after that event, with the same group which you see today, hardly there were 40 doctors from all over, and everyone had to be called personally, ki, please aao, dekho kya hota hai. But we formed a group that day on the advice of Professor Jha and Dr. Sanjay Agarwala. Sanjay is a great friend. Unfortunately, he is not coming this time. There was some confusion of dates. Ultimately, the program where he was going has been cancelled also. So we formed a group, a society, and started doing the course every year, trying to bring some new things. Whatever is happening in the world, let the doctors of this Central India or the Hindi heartland, which is known as, be aware of that. In so many years, we have crossed many waters and many rivers, so many time has passed. So still, the focus is shifting, but the concept is same. We want the doctors to be apprised of all the new things which is happening, what are the new things which is on the horizon. But apart from the role of didactic lectures and live surgery, we are shifting to the case discussion. We want the panelists, the doctors from all over India to see what our colleagues are doing in this part of country. And then we can learn from each other. So now the era of didactic lectures is less, and it's going to be a very great interactive session for the 2 years. As far as the shaping the future, we will apprise you of robotics, what it is, and the virtual reality we started last year, and I have trained many doctors, and we can take pride in that. If you go to the Bihar, part of the MP, Uttaranchal, many doctors have come here and they all say, if out of 100 attendees, when one converts to a better technique, gets one better outcome in his patient, I think our purpose is served. So I hope you will all have a great time, and our team will take care of the hospitality all the time. Thank you, thanks for coming, and have a great day.
I request Dr. Prasad sir to be as a moderator of this session.
The first session is again by cases from our own team, or rather our own people from this Central India. And I would like to invite as a panelist Dr. Nabil Garib, who has come from all the way from Israel. He's a great surgeon, works on robotics, works on direct anterior approach to hips also, and will be enlightened by him in the course of the day. Dr. Dharmen Singh, please come as a panelist. And I don't know, Dr. Ajit Singh, And Dr. Sunil Kumar. Sunil had come? No. No, he is not here. In fact, we have got some issues on the traffic as far as I was informed in the morning also. Let's see, but we three are great. And let's start with the case presentation. Dr. Pradeep Gupta, total knee arthroplasty in primary knee, the first one.
Good morning, all of you. I am privileged to be here. I invited as a case presenter in session, case presentation session. Thanks a lot, Dr. Prasad sir and organizing team. And my case, my talk, total knee arthroplasty in primary knee. Clinical presentation. My patient, 55 years old male, come in OPD with chief complaint of pain in the bilateral knee. Yes, sir. My patient, 55 years old male, will come in OPD with chief complaint of pain in bilateral knee, deformity of bilateral knee, and decrease of the movements. Pre-op workup and planning for surgery. Patient X-ray, bilateral knee, AP and lateral, standing, and scanogram. Pre-op pictures and videos. On examination, swelling in the present in the both knee and capitus present in the both knee and more in right knee. Varus deformity is present. Flexion deformity in 10%, 10 degree. Pre-op pictures and videos are shown. Intra-op pictures and midline parapatellar incision are given. This is first tibial cut, then femoral cut, then implant inserted. These are my whole team. Immediate post-op radiograph, AP and lateral view with implant. Post-op rehabilitation there, patient in toilet, pen, and start in the knee static immobilizer with backing support with backer. The pen toilet and ROM exercise is started.
We have seen that. Anything extra you want to add?
No, sir.
Anything extra then?
No, sir.
Okay. So the age is only 55.
Yes, sir.
Why did you use the knee brace post-op?
First day, sir. First day knee brace, and
Again, I will have
pen
to
can
answer.
tolerate
Then?
easily. Pen in similar can tolerate, and static pneumalizers are backing with support उसके लिए.
Okay. Dr. Nabil, anything different you would do or what you would like to add?
I still didn't understand why did he use the brace after surgery. the knee brace.
Yes, sir. Yes, sir.
Why did the patient use the knee brace after surgery? Is this a limiting brace?
Yes, sir.
And why is that?
90,000.
So, what? Do you use knee brace for walking for all your patient after total knee?
Yeah.
Oh, okay. And why you are afraid of what,
Yes.
MCL injury or
No, sir.
no, just for protection?
Yes, sir.
Okay.
ये पोस्ट ऑफ रेडियोग्राफ आफ्टर 6 वीक
One more comment about your post-op X-ray. Patient had preoperatively 15 degree of FFD, but still this I can see the posterior osteophyte in the femoral, condyles, posterior condyle.
Yes, sir.
There is tendency of developing FFD if the patient had pre-op FFD. If you not remove the osteophyte and the femur posteriorly, there is a high tendency of developing FFD.
सर एफएफडी तो रिमूव हो गया सर, 10 डिग्री था। ऑपरेट करने के बाद में पोस्टर कैप्सूल को रिलीज करते हैं। पोस्टर कैप्सूल इज द रिलीज एंड देन
This is commenting on the osteophyte, the femur. That's why I commented on this. So usually what we do, if we have the pre-op FFD, so we remove the osteophyte from the femur posteriorly and release the capsule. That is the surety that patient post-operatively will not develop FFD and will not need lot of effort on rehabilitation to correct the FFD.
यस सर, यस सर। बाकिंग वीडियो आफ्टर 3 months।
Okay, Dr. The only thing I want to clarify one. Long knee brace is not required.
यस सर,
It is only required when you have got some element of doubt,
Yeah.
either on your outcome, on the soft tissue balancing, or a bone structure where you want to give some support to the joint. Otherwise, it's not required. So don't make it a routine habit. It has to be used in selected cases where definitely it can be patient-related things where you would like to use a knee brace. But it has to be very specific. It cannot be a routine thing.
यस
The focus should be on balancing. If you have it balanced well, it will work well. And number two, the very important point which Dr. Saab pointed out, osteophytes have to be removed. All the osteophytes are extra bone. They are basically, the posterior osteophytes are touching the posterior capsule. They have to be removed. You get a good amount of movement, it's okay, but conceptually and principally, the osteophytes have to be removed. You have to restore all the normal anatomy.
यस
If you cannot remove, there has to be some specific reasons. Yeah, because of this, I left it because it could have done some damage. So that's all. Okay. Thank you, Doctor.
One more comment. Probably the expression for this brace, when you have FFD and you thought that the post-operative patient may develop FFD, so you put brace for 6 to 8 hours in the knee extension that stretches posterior capsule and tissue, that helpful in reducing the post-operative development of FFD. So one explanation for this brace post-operatively, day 1, but not for the other days.
यस
So, friend, that was the most simple total knee replacement. Okay, Doctor. Thank you.
थैंक यू।
And now, just graduating, Dr. Anupam Srivastava, Dr. M.C. Saini. Okay. Dr. M.C. Saini, let's see. Last year he gave a very good hip case also.
Excuse me, sir. Hello.
Looking forward to your case.
Sir, you said that in case of FFD, wear the knee immobilizer for only 1 day.
Yes.
Any reason or can extend up to
Because it is not routinely done. You release the sir has already raised that you release the posterior capsule, remove the osteophyte. Mostly you'll able to correct the FFD. Even if you have a doubt in mind that tissue is a little tight, then you give the brace while patient in anesthesia. You give brace, keep knee extension. That helpful in stretching the posterior capsule and posterior tissue. That is helpful. In the first few hours, 6 to 8 hours, after the anesthesia is over, probably this brace is of no use.
Thanks, Cawnpore Arthroplasty Society for inviting me again to speak some topic revision knee arthroplasty in infected cases.
Absolutely a surgeon's decision, right? So if a surgeon feels that he needs to brace something, it's fine, but there has to be a reason for it. Number one, you are going into a slight FFD, but I would believe that if it's an osteoarthritic case, get them in full extension on table. If it's a rheumatoid, 5 degree is probably what you're aiming for, that's fine. But again, then don't need to brace for that. That will correct. That's number one. Number two, some patients have got quadriceps weakness, like the gait you just saw. He was just about toggling around. He will probably have a lot of quadriceps weakness. So test that clinically beforehand. That will not correct immediately after you do the surgery. So patient may have a tendency to fall down. So in those cases, it's okay to brace. So that's a surgeon's decision. Occasionally you have to brace, but it should not be routinely used because that's got a harmful effect also. Patients, if they don't use mobility during walking, that's actually got a harmful effect also. So use very judicially, occasionally is okay.
Indication for brace is that just an extension. If the patient is also having bilateral knee and it's been varus or valgus for a long time, suddenly you give him a new knee, probably for 1 or 2 days, a brace or a protection is good because patient has to use with the new kinematics of the joint. So that is also important. Sometimes in extremely varus and patient has been there for a long time. And the other knee is also bad and you have not done a bilateral in the same sitting. Probably a brace is a good idea when the patient is walking or you are not sure that that's set, test the quadriceps. That is very important. How is the gait?
Basically, it can be used as a confidence building measure for the patient.
Yeah.
That's all.
And sometimes in rheumatoid, we routinely use it because we leave it in a 10 degrees, 5 to 10 degrees of flexion and slowly it stretches out. You tighten the brace and it stretches out over a period of time. So you may use it because ligaments are very, very lax. You don't want to stretch it further when the patient starts walking. So that is one indication where I routinely use a brace, no matter whether I have released or not.
So basically, using a brace is a patient-centric issue. It cannot be, as a rule, every knee you will use a brace. You have to identify a patient where you think yes, some type of support for some time can be utilized, then you use a brace.
Now the revision knee arthroplasty in infected knee. The case is 57 years old female, was operated for knee replacement around 6 months back and having infected sign with severe pain and swelling occurs after 3 months and a patient unable to walk, having zero purulent discharge and primary surgeon did the debridement and implant retention surgery is already done one and again this is the X-ray in the primary surgery. The symptoms after this debridement, again first debridement, symptoms reappear again after 1 month and patient go our center with having same complaint of infection sign, with having severe swelling and pain and unable to walk and fever. On blood investigation, TLC, ESR, CRP is raised. On culture sensitivity, Staph aureus is bacteria present. Now the clinical picture, patients having a sinus on the medial side of incision, having a zero purulent discharge, is coming out, and now the various dilemma, the repeat debridement and implant retention surgery or either implant removal and debridement. And 1 stage in 2 stages, spacer, non-spacer, do the arthrodesis or revision, TKR. In arthrodesis, do the needs more of more bone graft, and infected do the arthrodesis in infected knee. It is also a very big thing. Now the proceed the case in the revision TKR. Now on further plan, to build up the patient, general condition, the patient build up, and do the 2 stages. First stage I did it thoroughly debridement and implant removed, and hold the debridement by the removal of synovial tissue and infected synovial tissue and tissue inside the femoral and tibial canal. All the tissue are removed and lavage with the antibiotic loaded solution as the culture sensitivity is specific. When on the culture sensitivity antibiotic are meropenem, linezolid and vancomycin are there. And apply the antibiotic loaded cement spacer by the static to 2 kind static. I applied here is used a static kind of bone spacer, and it makes by 2 bucket of cement with 2 gram of vancomycin. The antibiotic is used, start the antibiotic with the culture specific, meropenem especially, and serial monitoring of ESR CRP done. On the, after the implant removal on this implant, all the, and now the clinical picture by the antibiotic loaded spacer is mixed by 2 packet of cement with 2 gram of vancomycin. And after 2 weeks, patient started to walk over the cement spacer. And on when to plan for second stage, and patient when become afebrile and skin soft tissue looks healthy and no pain, feel no pain, and ESR CRP comes to normal. On culture, again serially at least 2 times did the aspiration, knee aspiration in aseptic precaution, and there is even no find of any growth. Now the uncement patient is barking of the cement spacer, and it may lead to the depressed lateral femoral condyle was barking, and now after that in second stage the various challenges are adequate exposure and removal of spacer, addressing the bone defect, bone loss, and keep the whole inventory inside the OT like a CC screw, Harvard screw, plate, and metal cone, and constrained knee, fully constrained knee, hinge knee. Though you have to be keep all the inside before the second stage surgery, reimplantation surgery, you have to be keep all the thing inside the OT. Even though allograft is possible. The selection of implant is a selection of implant, constrained, semi-constrained, and restoration of a joint line, stability, and don't forget the patellofemoral kinematic. And this is clinical photograph and showing the lateral femoral defect, which is covered by a bone graft taking a femoral notch and fixed by the 2 screw. And now the, after trial verified, the original implant is cemented with a long rod, long cement stem. And the X-ray is showing epilateral view, showing legacy condylar constrained knee implant with the 2 screw over the lateral femoral condyle. Now this is after 2 weeks, the picture, the soft tissue looks healthy and no sinuses, and all the sinuses are healed. And after 1 month, patient is movement, range of movement, and after 1 month, patient is able to walk with little support. Until follow-up of me, there is still no infection sign, and patient is walking painless. Now, the take-home message. An assessment of organ is thoroughly debridement and with lavage with antibiotic-specific solution. And stages procedure, explained and informed consent, addressing the bone defect, and restoration of joint line, and keep all the inventory inside the OT, as keep maximum, and irrespective of that, patience is the key. And thank you.
Thank you, Dr. Saini. Just one point. It looks good, but there are many people who will do same thing in a different way, and ultimately it's the outcome which is important. What was the point, how you will assess to or try to restore the joint line in a revision scenario? What's your point?
The point two, sir, during the trial implant, assess the joint line to see the patellofemoral kinetic, to check the patellofemoral kinetic.
Okay. Dr. Nabil, anything you will do differently in this case? Any implant, choice of implant, anything you would do differently to get a better outcome?
Well, I think I would do everything the same. It's also, I like to use articulating spacers in the first stage. Unless there's a severe soft tissue damage, then I will put the knee in full extension and not let them bend. I think in revisions we have to think more about sleeves and uncemented fixation, because I see many patients with these long cemented stems get loose at the end after 5-10 years. So we have to look for better fixation that can stay for a long time, more than few years.
Yes, I think, sir, you have done a good job. It's very challenging to treat the infected knee.
Thanks.
And you have shown the good results. So, but the one that the consensus, maybe there's some controversy about the operating knee revision, putting the implant after the spacer is 4 weeks or 6 weeks. Some literature say that do it on a 6 week because the antibiotic spacers release antibiotic inside is 4-5 weeks. After the two plan for the revision, you check all the blood parameters and all. Do you have any experience for the frozen section while putting the implant after removing the spacer?
My experience is, sir, if you do the first debridement, if the first debridement is very thoroughly done, and after debridement to keep the patient on the injectable antibiotic, especially to keep the continuous injectable antibiotic. And my cases, I'm doing that after 3 weeks, again, antiseptic precaution, knee aspirate and look the growth. And even the fluid, aspiration of the fluid stand for CRP also, for the fluid. So serial monitoring of CRP of the blood and as well as a fluid, joint fluid is doing really. My concept is that to see the CRP is below the 5. If it comes to below the 5, then I plan for, again, for reimplantation surgery. In spite of that, before reimplant, again I send for culture sensitivity under aseptic precaution of the joint fluid. Then when I am sure that everything is okay, tissues looks healthy and patient is painless, not so pain, so then I plan for whatever 6 weeks or either 8 weeks. So literature is recommended after 6 weeks. If it become 8 weeks or 3 months, it is okay, I'm continue if the CRP is not coming to normal.
Anybody has experience of frozen section perioperatively while putting the implant?
So we do have facility of frozen section, and if you are in doubt, it's very helpful. Only thing is, you have to be pretty sure initially before you start that its knee is quiet. But in case of doubt, keep it ready. It's very helpful, extremely helpful. We have patients in whom CRP was normal, suspected to have infection. Patient came for revision, and tissue looked not that good intraoperatively. Did frozen section. It showed more than 5 neutrophils per HPF, and later on it grew pseudomonas. So joint might look very quiet. Aspiration was negative. CRP was okay. It was hip. So we learned a great lesson that even in doubt, and in majority of cases now, even if you're doing one stage, we do send it. It's helpful. We find it extremely helpful. One question in my mind, how many of us are regularly aspirating the joint before doing second stage? What is the opinion of house? Are we all doing it? Dr. Rajkumar, are you doing it?
If the patient is, blood parameters are reasonably in the downward trend from the first stage to the second stage, and you are having a Simmons pacer waiting for 2 months, during that time, if you take your serial blood parameters, if it is in the downside trend and almost normal, then the literature says the second stage aspiration doesn't have any value. So because there are again false positive, false negative, so many things confuses the surgeon as well. So how you are taking the aspiration, if there is a mild growth, contamination, all those things, you have to go ahead. Now things are moving more towards first stage, one single stage revision. So I don't think an aspiration.
If you do the aspiration before the second stage, so aspiration is also give the culture sensitivity in spite of also you can test for CRP also. That gives a little confidence to surgeon.
I have some experience about single stage revision, not very much, but if you have the bug, if you have the bacteria in the first stage after the infection, and you have a sensitivity to oral antibiotics, then you can do and have similar results to two-stage revisions. But you have to treat these two operations as two different operations. Take out the implant, close the wound, shift the patient to another OT, and then change the scrubs, everything changes, and then do it as a second thing, and you get almost comparable results. But you need to have the bacteria in the first aspiration.
Can I ask last question? And how many times have you changed your decision based on aspiration prior to second stage? How many times have you changed your decision? Has it grown something? Because that's a protocol, people are doing it. But how many times it has become practically useful to you?
Sir, I can only recollect one case. Her CRP was never coming back to normal. But then she had a raised CRP even before the first primary operation. She was a rheumatoid. So this patient used to come 1.5 times the normal CRP, but never coming back to normal. So we were very jittery about her. We did aspiration, again we grew something. So we did a redebridement for her. And then after that she settled down. So it does happen occasionally. I don't think we should be that dogmatic that I will not do. What is the harm in doing one more aspiration? But after stopping of antibiotics for at least 2 weeks. So if you follow that trend where 6 weeks of treatment you've given, 2 weeks of rest period, re-aspiration another 3-4 days, you will not get your operation done in 1 month, 1.5 months, 2 months. It will be around 2.5-3 months.
And in our practical area, sir, stop the antibiotic for 1 week before aspiration.
Thank you, everyone. Thank you. Chaneen. Thanks, everyone. There's so many things. I'll just summarize. It is not the duration. You must ensure after the first stage that your case is ready to be operated. By many means, one of them is definitely aspiration, but all other parameters do help. So it's a clinical evaluation helped by the biochemistry. And yes, during operation, frozen section will give you some idea. No, normally our pathologists are trained to look for malignancies in frozen section. So they have to be told that yes, you are looking for inflammatory markers or inflammatory cells. So yes, that will help, and sometimes in case of doubt, you may postpone doing a final revision case. So yes, all the parameters do help. And we'll change our panel. Thank you, Dr. Nabil. Thank you, Dr. And then I'll call Dr. Simon Thomas and Dr. Anil Arora as a panelist. And I'll be calling Dr. Uttam Garg, a good friend of mine, to present his case.